Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast my dear friend and colleague, and also the Associate Editor, Dr. René Pareja. He's at the Instituto Nacional de Cancerología, Department of Gynecologic Oncology in Bogotá, Colombia, and also at the Clínica Astorga in Medellín, Colombia. We're going to be talking about this very important article. It'll be the April lead article, and it is titled Efficacy of Topical Treatments for High-Risk Human Papillomavirus in Preventing CIN2 plus Lesions, a Systematic Review. Renee, thank you very, very much for accepting our invitation to doing this podcast. And I'm really looking forward to having this discussion.
Thanks, Pedro, for having me again in a short time. It is a pleasure to be here with you.
Excellent. So, Renee, obviously a hot topic in the field of pre-invasive disease. We have lots of questions, and I wanted to start by asking you first. Now, there are many topical agents that claim to promote HPV clearance. Question is this valid? Or is this restricted to a certain population? What clinical issues were you hoping to address or clarify with this review?
Thank you for the question. Some topical agents have shown signals suggesting increased HPV clearance in small studies. However, these findings are inconsistent and often observed in highly selected populations. Most importantly, HPV clearance alone does not necessarily translate into a clinically meaningful benefit because the vast majority of HPV infections will disappear spontaneously without any intervention, will become undetectable ones. The main clinical question we wanted to clarify with this review was whether topical treatments actually prevent progression to clinically significant disease, specifically CIN2 or higher. This is the threshold as with treatment becomes necessary and therefore represent the most relevant outcome because low-grade lesions are CIN1 do not need any treatment according to major guidelines.
Excellent. So, can you walk us through the study design that guided this systematic review? And why did you restrict inclusion to randomized control trials rather than also including observational studies?
Thank you, Pedro. Because randomized controlled trials provide the highest level of evidence to establish treatment efficacy. Observational studies are highly vulnerable to confounding, particularly in HPV infection, where spontaneous clearance is extremely common. If observational studies are included, an intervention might appear effective simply because the infection would have cleared naturally. Restricting the analysis to randomized clinical trials allowed us to answer the question with the most rigorous methodological standard possible.
Great. So we're going to get into some of the questions from our fellows. Ilker from Turkey is going to ask about, you basically focused on women with HPV infection or CIN1, but you excluded CIN2 plus. What was the rationale behind this decision?
Thank you, Ilker, for this interesting question. We intentionally focus on women with HPV infection or CIN1 or low-grade SIL because this is the stage where the question of topical therapies is most relevant. CIN2 plus represent established precancerous disease or stage where treatment is already recommended due to the meaningful risk of progression to invasive cervical cancer. In contrast, HPV infection and CIN1 generally have a favorable natural history, with most cases regressing spontaneously through host immune response. For this reason, no major clinical guideline recommends treating HPV infection or CIN1, particularly with topical agents. Instead, international bodies such as the World Health Organization, American Society of Colposcopy and Cervical Pathology, and the European Federation for Colposcopy recommend observation and surveillance as the standard of care. Importantly, topical therapies are primarily marketed in this early stage population where clinicians and patients may feel uneasy with observation alone. Our review, therefore, focused on this group to address the key clinical question. Do topical therapies prevent progression to clinically meaningful disease, such as CIN2 or higher? Based on the currently available evidence, the answer remains no.
Excellent. So, question from Vincenzo Tarantino in Policlinico Gemelli. He says, your review required colposcopy or histologic confirmation and high-risk HPV testing. Why were these criteria important when defining the study population?
Okay, thank you, Vincenzo. This was a deliberate methodological decision to ensure the study population was accurately defined. When evaluating whether a treatment prevents disease progression, precise diagnosis is essential. While cervical cytology is an excellent screening tool, it has limitations as a diagnostic endpoint. Its sensitivity for detecting high-grade disease is only about 50%, meaning a substantial number of CIN2 plus lesions might be missed. At the same time, cytology may produce false positives related to inflammation, transient HPV infection, or reactive cellular changes. Relying solely on cytology therefore risks misclassifying patients, potentially including women who already have CIN2 or those who do not truly have disease. Similarly, confirming high-risk HPV infection is critical because persistent infection with oncogenic HPV types drives the development of cervical cancer. For this reason, we require colposcopy or histologic confirmation together with validated high-risk HPV testing. This ensures that the trials evaluated a well-defined and biologically relevant population, which is essential when determining whether an intervention can truly alter the natural history of HPV-related cervical disease.
Excellent. So now what we want to do is talk about the main findings of this review. What are some of the highlights that you want to bring up in this review?
Okay, Pedro, we identified 305 studies, but after screening them, 16 randomized trials were evaluated in detail. However, none met all eligibility criteria, and therefore no trials could be included in the final analysis. Most studies examined surrogate endpoints like HPV clearance or cytological regression rather than progression to CIN2+. Some studies even included things like repair of the lesion after 6 months of treatment, concordant colposcopy observation, cervical re-epithelialization, vaginal health, among others. The main finding is that there is no high-quality literature supporting the use of any topical compound in order to prevent progression to the real pre-invasive condition.
So now, a question from Giuseppe Parisi in the Policlinico Gemelli, and he is asking, what were the most common methodological issues that led to trials being excluded?
Thank you, Giuseppe. The most common frequent issues were inclusion of women with already diagnosed CIN2+, lack of histologic confirmation, which is critical, absence of high-risk HPV testing, combined or systemic interventions rather than purely topical therapies, lack of placebo or observation control groups, and the most common is the use of surrogate endpoints rather than clinically meaningful outcomes, such as cytological outcomes, immunohistochemistry markers, colposcopic appearance, etc.
Beate Sarta from Latvia is asking, one striking finding is that none of the 16 randomized controlled trials met all the inclusion criteria. Were you surprised by this result?
Thank you, Beth. Yes and no. We expected to find methodological limitations, but the complete absence of adequately designed trial was just striking. It highlights a major gap between clinical marketing of this treatment and the strength of the evidence supporting them.
Excellent. So now, René, this question comes from Anusha Kamath in India. She's asking, is progression to histologically confirmed CIN2+ the most appropriate primary outcome for trials evaluating topical therapies for high-risk HPV infection? Or Could surrogate outcomes like HPV clearance or cytologic regression still be clinically meaningful?
Okay, Anusha, the answer is yes. CIN2+ represents the clinically meaningful point in the disease pathway. Surrogate outcomes such as HPV clearance or not detectability or cytologic improvement may be biologically interesting, but they do not necessarily translate into a reduced cervical cancer risk.
Excellent. Now, this question is from Leila Abuladzi in Georgia. And she's asking, your review highlights that most HPV infections clear spontaneously. How should this natural history influence how we evaluate new interventions moving forward?
Probably this is the most important question so far in this podcast. The natural history of HPV infection is essential when evaluating new interventions. Most infections become non-detectable within 1 or 2 years due to immune control, so any proposed treatment must demonstrate benefit beyond that what occurred spontaneously. Experts from the IPBS, International Papillomavirus Society, have also recommended avoiding the term HPV clearance because current molecular tests only detect the presence of absence or viral DNA at a specific time, and a negative test does not prove that the virus has been eliminated. HPV may persist at a very low levels or remain latent in basal epithelial cells. For this reason, the preferred terminology is detectable or non-detectable HPV infection. The distinction is important when assessing intervention because infections naturally fluctuate between detectable and not detectable states. Studies that rely solely on transient negative HPV tests might overestimate treatment effects. Therefore, new therapies should demonstrate clinically meaningful outcomes, such as preventing progression to high-grade disease, rather than simply reporting short-term changes in HPV detectability.
Excellent. So as a follow-up question to that, Alvin Matthew from Houston Methodist Hospitals, he's asking, if you were to develop a randomized control trial assessing the efficacy of topical treatments to prevent the progression of HPV-associated cervical pathology, what key parameters for the study would you consider to be most important?
Thank you, Alvin. An ideal trial should include confirmed high-risk HPV infection, histologic confirmation or CIN1 or less, placebo or observation control group, adequate sample size with power calculation, and this is missing in almost all the literature related with the issue. Long enough follow-up, like several years, up to 5 years, because there are publications even evaluating the response after 3 months or even 6 months, and the only trial assessing the response at 1 year is a negative one. And additionally, the primary endpoint should be progression to CIN2+.
Very well. Nicole Chris from University of Western Australia is asking about genotypes of HPV. She said, should future trials stratify by HPV genotype or persistence status?
Thank you very much, Nicole. Absolutely. The risk of progression varies dramatically by genotype and persistence status. For example, persistent HPV-16 infection carries a far higher risk than a transient infections with other genotypes. Stratification would really improve trial interpretability. I would like to state that the risk of developing a cervical dysplasia after a 16 HPV infection is 6.3% after 9 years of follow-up. All the rates due to infection by the other genotypes present lower figures than that.
Lucia Ribeiro from the European Institute of Oncology in Milan, she's asking, your implications section calls for better design trials, but given that this field has been investigated for decades without producing adequately designed trials, at what point should the research community ask whether we're investing in the right interventions or whether the future lies in systemic approaches, immune modulation, or other strategies entirely?
Thank you, Lucia. This is an important and somewhat uncomfortable question for the research community. Topical therapies for HPV infection have been investigated for several decades. Yet, despite this long period of study, we still lack well-designed randomized trials demonstrating that this intervention prevents progression to clinically meaningful disease such as CA1-2+. At some point, it is reasonable to pause and reflect on whether continued investment in these approaches is justified, particularly if the biological rationale and clinical evidence remain weak. The most important consideration is the broader public health context. The WHO Global Strategy for Cervical Cancer Elimination, often referred as 90-60-90 targets, aims to achieve 90% of vaccination coverage in women younger than 15 years, 70% screening coverage at 35 and 45-year-old, and 90% of treatment of precancerous lesions and cancer. These interventions have robust evidence supporting their effectiveness. The risk with poorly supported intervention is that they can distract both clinicians and patients from these evidence-based priorities. If patients believe that topical products can eliminate HPV infection or prevent cervical cancer, they might place less emphasis on vaccination, screening, or appropriate follow-up intervention that are proven to reduce disease burden. Therefore, while research should certainly continue, it is essential that the field remain focused on intervention that meaningfully contribute to the WHO elimination strategy, rather than diverting attention and resources toward approaches that have not demonstrated clinical benefit.
So to that, you mentioned, of course, obviously, what do we tell our patients? And this question from Leila Abuladzi in Georgia, she's asking, for clinicians who see patients who are asking us about these treatments, how should we counsel patients? There is a growing commercial promotion of topical HPV treatments. What message should we take from your findings regarding these products and conveying that to our patients?
Thank you, Leila. This is a very important aspect. Clinicians should explain that most HPV infections resolve naturally. No topical therapy has proven to prevent CIN2+. Observation remains the guideline-recommended approach. Patients should be cautioned that commercial products might be marketed aggressively despite insufficient clinical evidence. And additionally, one thing that the patients really need is a physician sure on what he or she is saying. I used to take a sheet of paper and to use my hand to explain them, the numbers, the figures, the risk progression, the clearance, and explain them carefully that they should make a reservation 1 year later, 1 year and a half, 2 years later, and a kind of sound in her cell phone in order to come back to the follow-up visit. But they don't have to be concerned about observation because it's the recommended approach by major scientific societies.
So with that, René, the next question is, what should you be telling other physicians, other clinicians, when they ask you, what about topical treatment for CIN? What is your message to other doctors?
Pedro, the key message is quite simple. There is currently no high-quality evidence demonstrating that topical treatments prevent progression to HPV infection to clinically significant cervical disease. All of these studies are designed to treat untreatable diseases because in those conditions, observation is the preferred approach.
So René, as a last question, this question comes from AI and is asking a question written about your review. And I think it's also an important question because obviously physicians are going to be targeted by industry about promoting topical treatments for HPV. So the question from AI is, should the gynecologic oncology community push back more aggressively against the commercialization of topical HPV treatments?
Pedro, my answer is a strong yes, because the gynecologic oncology community should be more vocal about this issue, primarily to protect patients from misleading claims and low-quality evidence. Currently, there is no high-quality clinical evidence demonstrating that topical treatments eradicate HPV infection or meaningfully alter its natural history. HPV infection is typically self-limited and controlled by the host immune system, and no international guidelines recommends treatment of HPV infection itself. We used to treat the consequences of persistent infection. Organizations such as WHO and International Papillomavirus Society emphasize that HPV infection without high-grade disease should not be treated. When commercial products claim to eliminate or clear or cure HPV, they risk creating false expectations, unnecessarily anxiety, and financial toxicity for patients. More importantly, promoting ineffective interventions can divert attention from strategies that truly reduce cervical cancer incidence, namely HPV vaccination, evidence-based screening, and appropriate treatment of precancerous lesions. These pillars are central to the WHO 90-70-90 elimination strategy. Therefore, clinicians, scientific societies, and journals should advocate for rigorous evidence standards, challenge unsupported marketing claims, and ensure that patients receive accurate, evidence-based counseling about HPV infection and its management.
Excellent. Well, thank you so much, Renee, for that opportunity to discuss this very important topic, which again, I mean, I think it raises awareness to the community, not just for clinicians, but also for our patients. So I'm really glad again that we're getting an opportunity to discuss this as well in our upcoming journal club in April. Once again, congratulations for putting this together, you and the authors, and all the contributions you continue to make to Gynecologic Oncology. Thank you once again, and we look forward to seeing you in the journal club.
Thank you very much, Pedro, for this kind invitation.